So I just introduce you to the instructors. My name is Dr. RISHI SWARUP. I am from Hyderabad. I in private practice, and my hospital is called SWARUP Eye Center. My co-instructors, Dr. Rajesh Fogla, one of the senior cornea surgeons in India, and he is a prolific DMEK surgeon, and he'll be talking about some more advanced situations, and we all look forward to learning from him. Siddharthan is from Coimbatore. He's again a young dynamic cornea surgeon. He's doing a lot of DMEKs. Dr. Vikas Mittal from Ambala, again a good friend and a very good DMEK surgeon. Ashish Nagpal from Ahmedabad. He represents the Center for Cornea, Nagpal Center of Cornea in Ahmedabad, and again a very, very dear friend and a wonderful surgeon. So basically it's a collection of friends who also do DMEK. This is going to be the flow of topics. I'll introduce the topic and talk to you about the instruments for DMEK. Followed by my talk will be Ashish, who will talk about how to prepare your donor. Then Siddharthan will talk about how to put it into the recipient. And then Vikas will teach you how to practice for DMEK in a wet lab. Finally, Dr. Fogla will sum it up with some difficult DMEKs which he makes look very easy. And then if we have time, we'll do some discussion as well. So endothelial keratoplasty has been around for a while, more than a decade now, and it's been going through these stages of evolution. First it was posterior lamellar keratoplasty, then deep lamellar endothelial keratoplasty, then Descemet stripping endothelial keratoplasty, Descemet stripping automated endothelial keratoplasty, and we are at DMEK, and then people are also doing another procedure called PDEK. So essentially it's a revolution in evolution. So when DSEK worked so well, why do DMEK at all? I think the single common reason why one should do a DMEK is because it has much lower endothelial rejection compared to DSEK, and much lower than a penetrating keratoplasty. It gives very rapid visual recovery compared to any other form of keratoplasty, and it also gives you a much better visual recovery, higher chance of you reaching 20/20 vision with the DMEK compared to any other procedure. Earlier it was a much more difficult procedure because we were still learning it. I think now that people have been doing it for a while, we have understood some of the surgical nuances which have made the procedure more repeatable and predictable. So if you follow certain steps, you are likely to get a certain outcome. But before we get on to that, we must be careful to select our patients carefully. We must make sure that the donors are selected well. It shouldn't be too young, the donor tissue, otherwise they're difficult to unscroll. Avoid diabetics, these tend to tear while dissection. Avoid eyes in which the fellow eye had a problem during DMEK harvesting. And of course, because it's an endothelial procedure, you want to have a good count of at least 2,500. Patient selection is also paramount, especially in your learning stages. So make sure that you have good visibility. So if it's a scarred or a very edematous cornea, you probably want to avoid that. You should have an intact pupil, not a very big dilated pupil, and the iris should not be damaged. No vitreous, no blood, no synechiae, at least in the beginning cases. Avoid FA cakes, avoid deep eyes, avoid post-filtering surgeries. All these can have complications. Of course, these will be covered by Dr. Fogla because they are advanced scenarios. Wet lab practice is mandatory. I'm sure Vikas will teach us. And practice there's no shortcut for it. You have to practice. And before you practice on the patient, please practice in the wet lab. Observe lots of surgeries, listen to a lot of talks, ask questions to senior surgeons. I think this is one surgery which is probably the most challenging for any corneal surgeon. And if possible, try to have somebody supervise you for the first few cases. Start with simple cases like Fuchs, having a clear stroma, intact pupil, and AC should not be too deep. And I'll go on to the instrumentation part. I'll just quickly cover it because most of these will also be covered by the individual speakers. So basically there are two types of instruments. One is donor related and recipient related. And this is one surgery where the donor donor dissection is as important as the recipient surgery. Otherwise, most of the time the donor surgery is a small component of it. So you use trifines, you use several instruments to strip or grasp the desmus membrane, and you have instruments for marking the desmus membrane and some instruments to introduce the desmus membrane into the eye. So among the trifines, you've got initially you want to use a large diameter trifine to kind of separate the desmus membrane from its edge where it is attached. So usually you can use a 10 millimeter trifine. Some people use the Melis technique, in which they dissect the root of the desmus membrane along from the periphery. That also is a good idea, but you have to be proficient in that. So I use this technique, in which I just use a large trifine. Some people also manually cut it with a blade or have some sort of a stripper. So there are different ways you can do it, but I think this is what works well for me and would work well for most people. For this trifination, you don't need a full thickness trifine, you just need to cut the desmus membrane. So a guarded trifine, or even if you are using a full thickness trifine, don't punch it, just tap it, and that does the job. So you have several available from different companies. Yanak has one, Coronet has, and you can, like I said, you can even use an Indian basic handheld trifine also. You also need a trifine which is 3 millimeters. This depends on which technique you're using, but if you like to mark, then this is a very useful tool. So after you've stripped the desmus partially, in the anterior stroma you make a little window with a 3 millimeter skin biopsy punch, and from that you get a little window through which you can mark the eye. You also need a final trifine which you will cut according to the size of the desmus scroll that you want. So I usually use 8, but some people use 7.5 also. And it's always good to use a Hesburgh's Baron style punch trifine, because you can center it a lot better, because if you get decentration, then you'll have a problem. You can use specialized forceps which are broad based and have blunt tipped to strip the desmus membrane. I use a curved tie forceps, but these are also very good. The advantage is because you're using a larger, you're holding a larger area, you are less likely to tear it. You also need an instrument like a Sinskey hook to elevate the edge of the desmus after you've done the initial trifination before you grasp it. This was that window I was saying for marking. So you can create any asymmetric mark like an F or a P or an S. You can use it with do it with a regular Sinskey hook also, but you have ready-made marks available from different providers which have F, S or P stamps. So that's as far as the donor goes. For the recipient, again, you need to strip the unhealthy desmus membrane, so you have to use a reverse Sinskey hook, or you have specialized olive-tipped strippers which are available. So basically you want to score the desmus, not really cut, because if you have something sharp, it will cut into the stroma, which will cause a problem. And then you have to basically strip it. The same instrument can be used, or you have sometimes strippers which have a hook which can be used, or you could use a forceps and grasp and pull. There are different ways to do the same thing. After the donor has been inserted, the donor is inserted using various types of inserters. So you have glass tubes, you also have plastic inserters which are modified IOL cartridges which people use. I'll show you a video in the next slide. And after the scroll has gone in, basically, then you need to have specialized cannulas. 30 gauge cannulas or 27 gauge cannulas are used to form the anterior chamber, as well as with air, as well as to unscroll the desmus membrane. So that's a special cannula which has a tip at the top. If you have a very tight scroll, you can inject into the scroll to open it up. I'm sure the speakers will be talking about all these things. So this is a glass cannula. Glass is always better for desmus scrolls because it doesn't damage the endothelium that much. Various vendors provide. The one here shown is the one from DOC. You have from Goider and various companies. Even Indian companies are making them. I think Joja Surgicals has one here in the trade, no financial interest. And this is a homemade injector made by Dr. Siddharthan, one of our instructors. They are available from various people have made different ways. So essentially you need something in which it can go in, and he's using an IOL cartridge here to do the same. I'm sure this video will also be shown later, so I won't spend too much time on it. And I'll just end with this little innovation from Dr. Fogla, in which he's made a nice nice illuminated artificial anterior stripping block. So you have this backlight, and in this, essentially, because of that backlight, you're able to see the outline of the Descemet's membrane very nicely. I'll just forward to that. I think Kashish is going to show this video. So I'll just quickly run through it. So that's the initial trephination. I think it's commercially available now, I'm not sure though. So you can see the outline very well. So you can see the edge of the Descemet's is quite nicely visible. That's essentially because of the backlight. Okay, so that's as far as the instrument